The next presentation is titled Bradycardia, Syncope and Sudden Death. And my colleague, Usha Tedrow, who's director of the Clinical Cardiac Electrophysiology Fellowship, as well as clinical director of the Ventricular Arrhythmia Program, will be doing this. She's a member of the cardiovascular division at the Brigham and Women's Hospital, as well as being associate professor of medicine at Harvard Medical School. Thank you.
Thank you very much. It's my pleasure to be here in this unusual format for this conference. I hope that everybody's enjoying it. Here are some of my disclosures. And there's a lot to cover in not that long. So we're going to try to go a little bit quickly through a bunch of different topics. So we're first going to talk about syncope. So syncope concerns, is there, when you see a patient for the first time in the emergency department or even in the office with syncope, you want to know, is there a risk of sudden death? Is there a risk of serious incapacitation? Is there serious underlying disease? Is further medical evaluation needed? And you need to figure out, does the person need to be evaluated immediately in an emergent way, or can it be done electively? And this is one of my favorite studies on syncope. It dates back a few years now, back to 2002, but it looks at long-term follow-up of patients with different types of syncope. And I think one of the most important things is we see a lot of people with vasovagal or orthostatic types of syncope, and they followed these folks out for a long time, over 10 years in a lot of cases. And the patients that had vasovagal or orthostatic syncope had exactly the same outcome as folks that had no syncope. This is from the Framingham Heart Study. However, the patients with a cardiac cause of syncope had the worst prognosis. So I think when we're looking at our patients with syncope undifferentiated, I think that one of the things that we really want to try to decide is whether they have a cardiac cause of syncope. The history of syncope is extremely important, should include the situation, provocative factors, whether it occurred in a postural way, during exertion, the distinction between a mechanical fall, vertigo, orthostatic hypotension, and true loss of consciousness syncope. How the patient regained consciousness is really important. Did they regain consciousness immediately on becoming horizontal, or did they take some time to wake up? Were they confused afterwards? Were they not? Anyone that might have watched the event is very helpful. Keep in mind, however, that motor activity can happen with either cerebral anoxia or seizure activity as the primary problem. So things that are worrisome for a cardiac cause of syncope include the absence of a prodrome, so unheralded syncope, particularly from a seated position, is very concerning. Preceding palpitations or chest pain, syncope during exertion, as in contradiction to someone who has syncope after they've done exercising, which can be more benign. Patients who develop blurred vision before syncope, that could be indicative of low blood pressure, just preceding the syncopal episode. More reassuring clinical picture that suggests a non-arrhythmic cause include repeated episodes over more than 4 years, less likely to be malignant in nature, typical symptoms of reflex-mediated syncope, so provocative factors such as pain or anxiety or standing for a prolonged period of time, nausea during recovery. Those are all more reassuring. And then features typical of an orthostatic hypotensive episode occurring on standing or remaining standing for a long period of time. Of course, the past medical history is very important. A history of myocardial infarction, bypass surgery, angioplasty, cardiac medications are important in terms of increasing the likelihood that this is cardiac syncope, and abnormal ECG, and we'll look at some of those later in the talk. And then risk factors for coronary artery disease, as yet potentially undiagnosed in the patient. So age, hypertension, diabetes, smoking, hyperlipidemia, family history, and of course, family history of sudden death and cardiomyopathy are both very important. It's very important, particularly in our elderly patients, to take a look at their drugs that they're taking to see if that might have contributed to syncopal episodes. So looking at antihypertensive agents, vasodilators listed here, beta blockers, ACE inhibitors, ARBs, diuretics, centrally acting hypotensive agents. Other drugs can cause bradycardia, including beta blockers, calcium channel blockers, and others. Hypoglycemic agents particularly long-acting of a variety of different kinds, can contribute to syncope. Hypnotics that we use to treat many different neurologic conditions, including even restless leg syndrome, can cause orthostatic type syncope. Use of illicit drugs and alcohol can be contributors as well. But of course, we're all worried very much about QT prolongation that can be the result of some of the medications we give our patients. And QT prolongation can put the patient at risk for a particular type of ventricular fibrillation called torsade de pointe. And this can be a lethal arrhythmia. Certainly, many antiarrhythmic drugs prolong the QT interval through potassium channel blockade, which is part of their therapeutic action. But in addition, a lot of psychotropic medications, including SSRIs, can prolong the QT interval. Antibiotics, erythromycin, azithromycin, and others can be contributors. Should probably add under antimalarials these days, we're all thinking about hydroxychloroquine use, sometimes surreptitious in our patients. That can be a cause of QT prolongation in the COVID era. Methadone use is a common etiology of QT prolongation and torsade de pointe, as are protease inhibitors. And if you're wondering if you've got a patient on a new medication and you're not sure if that can prolong the QT interval, there's this website that's maintained by the University of Arizona called crediblemeds.org, and they keep a very good list of reported cases of QT prolongation and torsade for susceptible patients. This is from the guideline statement from 2017, the new syncope guideline statement. And I'd like to focus just a little bit on the cardiovascular part of this. So if you say this new way that they're doing the guidelines, it's all about flow charts, which I find a lot easier to read than the old way of just listing the different guidelines. But the idea is that you have syncope with evaluation and diagnosis. You do your initial evaluation. If you have a clear diagnosis, then it's clear how you treat it. But if your initial evaluation with history, physical exam, and ECG is unclear, and you have a person with cardiovascular risk factors, you sort of end up in this part of the evaluation, which can include a structural evaluation, including an echocardiogram, stress testing. If the ECG is abnormal enough, you might do an MRI or CT to look for different types of cardiomyopathy. An exercise test I really like doing in folks with suspected cardiac syncope, because I like it as sort of the poor man's EP study. You can sometimes induce arrhythmias with exercise that you weren't able to suspect previously with just limited monitoring. And then picking a cardiac monitor for your patient with syncope is really important. I think there are some patients that'll tell you, oh, I have a syncopal episode once a week or something like that. In that case, then doing a looping event monitor or even a patch monitor could be helpful in terms of making a diagnosis. But it's far more common that our adults with syncope have an episode once every 6 months or once every 8 months. And that's much more difficult to diagnose with a monitor that you have to put on, because they're not going to know, especially if they have unheralded syncope, when to put the monitor on. So we have these implantable loop recorders, small device about this long and maybe, a 1/4 inch wide, that can be inserted under the skin with a battery that lasts about 3 years, and that can watch the rhythm for that amount of time. And it's very useful for diagnosing rare episodes of concerning sounding syncope. So the ECG after a syncopal episode is abnormal in about 30%. It's diagnostic in less than 10%, however, which is why additional monitoring is often important. Things that you can see that could suggest an etiology of syncope include bradyarrhythmias, VT, of course, and signs of acute or recent myocardial infarction, markers for underlying disease, prior myocardial infarction, so Q waves on the EKG, Wolff-Parkinson-White with pre-excitation with a delta wave that you might see that could suggest that there might have been atrial fibrillation or an AVRT type of rhythm that could cause syncope. Brugada syndrome with ST elevations in V1 and V2, hypertrophic cardiomyopathy with signs of left ventricular hypertrophy, arrhythmogenic right ventricular cardiomyopathy or dysplasia with T-wave inversion seen in the proximal precordial leads of V1 through V3, and sometimes you might see an epsilon wave, which is a little notching at the terminal portion of the QRS complex, and long QT syndrome, where the QT is long at baseline without a clear provoking drug. So here are some examples of different types of bradycardia. And so first, let's talk a little bit about sinus bradycardia. Here you see a P wave and QRS. The QRS complex is narrow, but the sinus rate is very slow. Now, if you see a young, athletic, healthy person, particularly, a marathoner or someone who's a rower, a very fit person, they may have high vagal tone, and this could be completely normal. You could even do a 24-hour Holter on a patient like this and see transient episodes of AV dissociation due to high vagal tone, and that could be completely normal. This person, if you put them on a treadmill and exercise them, their heart rate will go up normally. They will show no signs of heart block as they exercise to peak exercise. In contrast, if this is sort of a 70-year-old little old lady who has maybe paroxysmal atrial fibrillation, this could be very pathological. And you might, on monitoring, find that they even have sinus pauses. When you have them exercise, you'll see evidence of chronotropic incompetence. You'll see that the heart rate doesn't go up as you wish that it would when they would exercise. And this kind of patient could need a pacemaker if they're symptomatic. Shown here is a different rhythm where you've got a P wave and a QRS, and the PR intervals are getting longer and longer on each one, and then you see a P wave here that drops with no QRS here. This is Mobitz 1 heart block, where it's this delay in the AV node. And sort of similar to sinus bradycardia, this could warrant pacing with a pacemaker only if the patient is symptomatic, but you don't worry in the case of delay in the AV node that they're going to go into complete heart block or lose their ventricular escape. Shown here, in contrast, is Mobitz 2 heart block. So notice here, the PR interval and the next PR interval exactly the same. Another P wave and the QRS is missing. You also notice here that the QRS is wide and abnormal, indicating some degree of bundle branch disease. So here, it's sort of the company it keeps. So the PR interval is fixed, and you have sudden loss of conduction, and you have an underlying bundle branch block. Putting this together is very concerning, and you worry that this person is at risk for developing a complete heart block, which is what you see here, where you see P waves going through that are a little faster than the QRSs, and here the QRSs, which should be perfectly regular if there's complete heart block present. And both of these situations are indicative of conduction disease below the AV node that need urgent, temporary, and then permanent pacing in most instances. So in general, the indications for needing a pacemaker are symptomatic bradycardia. So that can be sinus node disease or some kind of AV node disease or distal conduction disease. And this can be spontaneous or it can be drug induced. Sometimes we have people that are doing well on their own, but we give them a little bit of beta blocker, maybe to treat rapid atrial fibrillation. And all of a sudden they either have symptomatic sinus bradycardia or long Wenckebach cycles. So what do pacemakers do? Here's a chest x-ray of a person with a pacemaker. You can see that in their sort of left pectoral region. It goes into the axillary vein with the wires and down into the heart. There's an atrial lead here, which is hard to see, but then there's a lead in the right ventricular apex. So this is kind of a traditional pacemaker, dual chamber pacemaker. So electronic pacemakers can deliver electrical impulses that depolarize the myocardial cells near the lead tip, such that the signal propagates into the contiguous myocardium. And these pulses can be delivered in many ways depending on how the pacemaker is programmed. So there are many different types of pacemakers. They could have a lead in the right atrium. They could have a lead in the right ventricle, a dual chamber device like what I showed you on the chest x-ray on the previous slide, right atrium and right ventricle. And then there's something called a biventricular pacemaker, where we have pacing leads that are capable of pacing the right ventricle and the left ventricle to alleviate some of the delays that happen in the heart due to heart failure. pacemaker. And then there are ventricular leads pacing a portion of the His-Purkinje system. They can pace either the His bundle or the left bundle. These are kind of the new kids on the block in terms of ventricular pacing, and we'll show you some examples of that. So how does a pacemaker work when you program it to a certain mode? So here's a pacemaker that's been programmed to VVI mode. So that means you've got a ventricular lead. It's got an electrode tip at the end that can sense when the ventricular depolarization passes by the distal electrode. And when that happens, the pacemaker sees a spike that corresponds to some time during the QRS complex on the surface ECG. So here you see one heartbeat. Here's another heartbeat. And in this case, we've programmed the pacemaker at a rate of 60, which means that there should be 1 second between heartbeats. So imagine that this is a patient with, say, permanent atrial fibrillation, slow ventricular response, but sometimes they have a few beats on their own. So here's a beat on their own, another beat on their own, and then here's the timer that starts with this beat, and once it elapses and it does not see another intrinsic beat, it provides a pacing complex. And the pacing complex typically looks wide with a traditional pacemaker because you're pacing far away from the His-Purkinje system where there's a lot of myocardial local conduction. So a dual chamber pacemaker has 2 clocks. It has the heart rate, and then it has the PR interval, which we call the AV delay, which in this case we've set to 200 milliseconds. So here I put these together as one tracing just for simplicity, but inside the pacemaker they're separate. There's a tracing for the atrial lead and there's a tracing from the ventricular lead that are kept separate. So here you have a P wave that the patient has. The device waits 200 milliseconds to see if there's going to be a QRS complex. And if there's not, it paces the ventricle and produces a QRS complex. At the same time, the atrial lead is waiting for the next P wave to occur. And if that had gone more than a second, it would pace the atrium as well. But here the patient had their own P wave and they were able to conduct to the ventricle, so they have a native QRS. So you can see that depending on what the patient needs, you might see that there are times that there's pacing and times that there are not. If the patient's on their own with atrial and ventricular conduction, you'll see atrial sensing and ventricular sensing and no pacemaker activity at all. However, if the patient has intrinsic sinus node function, so they make their P waves on their own, but they have heart block underlying, you'll see pacing all the time. And in contrast, if you have sinus arrest but intact AV nodal conduction, you could see atrial pacing with conduction to the ventricles that occurs without additional pacing. And then there are patients that are dependent on pacing from both the upper and the lower chamber of the heart. So briefly, I just wanted to talk about something that comes up a lot, which is mode switching. So this is an example of a tracing from a patient with a dual chamber pacemaker. Here's the atrial lead and here's the ventricular lead. And what you see is that the atrial lead is showing little spikes that are going much faster than the ventricle. So this is what atrial flutter would look like from the standpoint of the pacemaker. You see rapid beats from the upper chamber of the heart, and you see these little slightly irregular ventricular response down here. Now, the way that we prevent the device from trying to pace every one of those flutter waves, is twofold. One is that we program an upper tracking limit for the device so it can't pace any faster than whatever we set, say 110, 120 beats per minute. But we also tell the device if the atrial rate goes too fast, and that could be over 150, over 170, whatever rate we've set, I want you to switch from DDD to a non-tracking mode. I want you to switch back to VVI mode, for example, and it'll keep doing that until the atrial arrhythmia episode is over. So let's talk a little bit about the couple new kids on the block with respect to pacing. So here's an example of a patient that's having a leadless pacemaker position. And the reason for the development of the leadless pacemaker is that the Achilles heel of every pacemaker or defibrillator system is the wire that goes from the shoulder into the heart. That wire is subject to heartbeats, and lung motion and pectoral muscle movement as stressed every day of the patient's life. So that is ultimately going to fracture and break for every pacemaker that is implanted. So this device was developed. It's called the micro device. There are other devices in development, but it's basically a small self-contained pacemaker about that big that can be deployed through a sheath that's introduced through the femoral vein. And this has little tines on the bottom that can grab hold of the ventricular myocardium. And then it's released there. And it basically sits alone in the ventricle. It can provide VVI pacing. And the new version of this can actually detect some of the pressure waves from the atrial contraction and provide some degree of AV synchrony as well for patients that are in heart block with sinus rhythm. The other new kid on the block is His bundle pacing. So this is achieved with a very small pacing lead and a special sheath that's negotiated to deposit the lead pretty much right on the very beginnings of the conduction system. And so you can see an example of this here. This doesn't look like a typical pacing lead that what you're used to is something that goes way down to the right ventricle here. But basically this lead would sit right on the His bundle. And the thing that's nice about that is you can pace the heart and achieve a QRS complex that's very similar to a natural QRS complex. So here what you see is with high output pacing, you often capture the conduction system as well as a little bit of neighboring myocardium, which makes the QRS complex a little bit wide here. As you turn down the output, you capture only the His bundle, in which case you get this nice normal QRS. And then after, in this particular patient, they've got an underlying right bundle branch block. So you can see when we stop pacing completely, this is what the patient looks like with no pacing. So it actually corrects to some degree the underlying right bundle branch block. This has now been adapted where you can insert the lead on the ventricular side of the tricuspid annulus and twist it into the septum a little bit and even capture parts of the diseased left bundle to recruit them for pacing. And the thought is that this may provide more physiologic pacing with less complications with heart failure with pacing down the road. So when you have a left bundle branch block pattern or pacing from the right ventricular apex, which also produces a left bundle branch block-like pattern, there are some consequences that happen. The QRS complex becomes wide, greater than 120 milliseconds. There's increased time to complete ventricular contraction because you have intact conduction down the right bundle branch, but then slow conduction across the left bundle. And the lateral portion of the left ventricle is activated last. So that leads to septal activation of the left ventricle, followed by lateral activation of the left ventricle, which can make the ventricle contract in a very dysynchronous way, and it can cause some mitral regurgitation because of sequential activation of the papillary muscles. It's also associated with worsening left ventricular function. So how do we correct this if we're not doing His bundle pacing or left bundle branch pacing? The traditional way is to do something called cardiac resynchronization, where here is an atrial lead, here's a ventricular lead, and here's the coronary sinus with some branches heading down towards the ventricle. We actually put a pacemaker lead in one of these branches in an effort to correct the left bundle branch block and re-achieve synchrony. So here's just an example of a patient with chronic pacing from near the right ventricular apex. Look at how wide the QRS is here. And after adding a left ventricular pacing lead, you can see how narrow the QRS has become. And this patient actually was able to come off the transplant list with this cardiac resynchronization therapy. So the people that benefit from cardiac resynchronization therapy are the folks with wider QRS at baseline. They have a left bundle branch block configuration. Women seem to do better than men, and folks with non-ischemic cardiomyopathy seem to do better than folks with ischemic cardiomyopathy, and that may just be because of fixed areas of scar that you can't resynchronize. So let's shift a little bit from talking about pacing to talking more about defibrillation. So we're going to talk about sudden cardiac arrest. There are basically 500,000 out-of-hospital cardiac arrests per year in the United States. More than half of these are in patients having a myocardial infarction. They have 95% out-of-hospital mortality, and our goals are prevention and recognition of high-risk populations. One of the biggest things that's happened in the public health community is the introduction of AEDs. In the national average, sudden death that's resuscitated in the community has a survival rate of about 5%. But in places where you can get EMS to your survivors more quickly, you can resuscitate them better. And if you're even closer, my favorite study is this casino study where they're actually watching you the whole time. They watch someone in the casino who's drinking and smoking and maybe doing some things that might increase their risk of having a cardiac arrest. They bring someone with a defibrillator as soon as they see you in the casino have an arrest, and they can improve your survival rate to 53%. The reason AEDs are so important is even though the risk of sudden death is very low in the general population is so numerous that they actually make up a large number of the patients having sudden death. The rest of the folks we focus on, though, are more the people with structural heart disease that have a very high incidence of sudden death, even though that they make up a smaller number of the sudden deaths per year. So how do we prevent this from happening early? Primary prevention of coronary artery disease, early identification of structural heart disease, and identification and avoidance of medications that increase risk. It's important that after a cardiac arrest, you evaluate for acute causes, myocardial ischemia or infarction, electrolytes or drugs, that you characterize the underlying heart disease, echocardiogram, coronary angiography or exercise testing, depending on which is appropriate. Consider cardiac MRI, and certainly electrophysiology specialists would be involved at this point. You'd consider an electrophysiology study for better diagnosis. This is an example of an implanted cardioverter defibrillator. There's, just like the pacemaker, there's a box in the shoulder and a wire that goes into the right ventricle that can defibrillate a rapid arrhythmia that can happen during a cardiac arrest. The new kid on the block is this subcutaneous ICD you may see that can shock the heart from outside the body. This also, similar to the leadless ICD, gives the opportunity to shock the heart with a lead system that's less prone to lead fracture. So I'd just like to finish up by talking about the indications for defibrillator implant. Shown here, we'll talk first about secondary prevention. So in general, most folks without a reversible cause for cardiac arrest should have a defibrillator implant. Those who have a reversible cause, you should try to revascularize them. Most commonly, those are folks that have had an ischemic arrest. But those folks should be watched carefully with monitoring down the road because they may be at increased risk of a cardiac arrest down the road, even if there is a reversible cause. Then patients who are primary prevention, folks with ischemic cardiomyopathy and an ejection fraction less than 30% need a defibrillator. Those with NYHA class 2 or 3 heart failure and an ejection fraction less than or equal to 35%, that's the SCUD-HEF trial, also need a defibrillator. And those with slightly better ejection fraction, non-sustained VT, and inducible VT at EP study also need a defibrillator. When we look at the non-ischemic cardiomyopathy population, the picture is a little bit more murky, but the randomized controlled trials would suggest that those who have had a cardiac arrest certainly deserve a secondary prevention device. Those with an ejection fraction less than 35% and class 2 or 3 heart failure deserve a device. And then there's some specific diseases. Here they mention Lamin cardiomyopathy, but there are also special populations that are at high risk for sudden death, including hypertrophic cardiomyopathy, cardiac sarcoidosis, long QT syndrome, Brugada syndrome, arrhythmogenic right ventricular cardiomyopathy, catecholaminergic polymorphic VT, and some of these others that are listed here that would also qualify for a defibrillator just on the basis of the diagnosis and some high-risk features. Should I pause there, or do I have a time to do a couple questions?
Thanks, Susha. Maybe give us the one question. Would that be okay?
Yeah, absolutely. We can do that. Let me scooch across here to do that. So here. So here's a question for you folks. This ECG suggests which of the following diagnoses? And maybe while you guys are answering, I don't want to give you the answer while you're answering, but do I need to do anything to start the poll? Is it going? Okay. I don't see it collecting any information from anyone though. Oh, there we go. Okay, great. 100% of the people got it right. Right. So this is hypertrophic cardiomyopathy. And you can see that there are signs of left ventricular hypertrophy with a very tall R wave and AVL greater than 11 millimeters. There is, we're getting a couple of people that said Brugada syndrome as well. Okay, so, and you add the S wave in V2 to the R wave in V5 here, and that also is greater than 35 millimeters, consistent with left ventricular hypertrophy. We see T wave inversions, V4, V5, and V6, as well as one in AVL, which are common repolarization abnormalities that we see in hypertrophic cardiomyopathy. So here the prevalence is 1 in 500. LVH or repolarization abnormalities are present in 85% of patients. They can have atrial fibrillation and actually very high stroke risk related to atrial fibrillation. And their sudden death risk is 1 to 3% per year. We see a lot of athletes with this problem and that present with sudden death. And I think their primary care person may be the first person to ever see the suggestive ECG. So I think it's really important. What I might do, if you don't mind, instead of doing the next questions, can I just show the ECGs?
Please.
Just take a minute. So this one here, I won't have you guys answer the question, but this is an example of arrhythmogenic right ventricular cardiomyopathy. And what you see is V1, V2, and V3. You can see T wave inversions here all the way out to V4. And you see this little notch at the terminal portion of the QRS complex here, and that is suggestive of an epsilon wave. So this is a classic ECG for ARVC. There we go. And I'll just skip over to the next. And this is an example of Brugada syndrome. I saw that there were a couple people that thought that the HCM, the hypertrophic cardiomyopathy ECG, looked like Brugada syndrome. But you see here that this looks quite different, where you have big ST elevations in V1, V2, and V3. You need to have more than 2 millimeters in 2 contiguous leads. And they have this particular coved appearance to the ST elevations. And these folks are at risk for sudden death due to nocturnal, typically ventricular fibrillation episodes. And then the last one is very obvious QT prolongation. So this is a person with congenital long QT syndrome. And so all of these ECGs are just syndromes that you should be able to recognize. And when you've had a patient with syncope, if you see an ECG like this, you can make the diagnosis just on the basis of the ECG.
Great. Thank you. Thank you, Usha. I really appreciate it. Perhaps I can just take a few questions. There's one question that relates to orthostatic hypotension among elderly. And obviously, as one ages, a number of changes occur, both electrophysiologic, but also with the baroreceptor reflex and other things. Could you speak a little bit about the approaches to treatment, at least from the vantage point of an electrophysiologist like yourself, with respect to orthostatic hypotension among elderly patients?
Certainly. This is a really, really big problem. I think with our older folks, as we mentioned earlier, they're very prone to polypharmacy, and some of the drugs we give them can blunt their reflexes on standing. I certainly, the simplest thing is to have the conversation with the patient to not jump up too quickly from a seated or laying down position, that they have to sort of tell them to say 1,000 as they stand up, certainly. But it can be a really difficult problem, particularly for some of our diabetic patients that are getting sort of a little autonomic neuropathy along with it. I hate to say it, but I'm a little permissive on their antihypertensive regimen. Like, you have to be a little careful that sometimes you can drive down their blood pressure, but then when they stand, they're really too tightly controlled. I think sometimes for some of these patients, the only way to get around it is to back off just a little bit on their antihypertensive regimen, but it's a very difficult problem.
Second question is about screening. So could you comment on outpatient screening echo for young athletes to rule out structural disease and reduce rates of sudden cardiac death in this population? And then relatedly, screening modality recommendations for relatives of patients with sudden cardiac death and their risk of sudden cardiac. Could you speak
Absolutely.
to
that? Those are really great questions. So the controversy actually for athletes starts even at the level of the ECG, like which athletes need an ECG in order to screen themselves in order to, like if you look in Italy, for example, everyone going into an athletic program in high school gets a EKG and they interpret it and they make diagnoses. The AHA came out with a statement about that, and they felt that there were too many false positive ECGs found in that scenario. So I guess my suggestion for the young, healthy person with no concerning family history and a normal ECG a normal physical exam would be to not get an ECG before embarking on exercise unless there's some concerning symptoms. It's almost like any test, you want a certain amount of pretest probability that you're going to find something. And then when the ECG or the physical exam is abnormal, I would let that guide your echocardiogram or your ECG or both. But in the patient that has a concerning family history, that should probably be someone referred to a specialist. So what we typically do here, we see a lot of families with sudden death, and we work together with the cardiovascular genetics group. We'll often get the family screened in a very careful way with the genetic counselors, decide if there is a family mutation that can be used to help screen their family, or if there's a clinical syndrome, we'll work on getting family members screened. So usually in the absence of a defining patient, usually will consist of an echo and an exercise test for all family members at the time that a heritable syndrome is appreciated.
Great. We have only 1 minute left, so I just wanted to give you 2 or 3 quick fire questions so you can just answer them quickly. So the first one is, which blood pressure medication does not cause severe orthostatic hypotension in the elderly?
I think none.
Okay.
That's I would stay away from alpha blockers, I guess, is the only thing I would say. And just pay attention to your patient. There may be different patients, like someone who's got a lot of underlying bradycardia may not tolerate a medicine that slows their heart rhythm down, but I think there's really none. No.
Has the tilt table testing fallen out of favor in evaluation of syncope?
Yes, I would say so. It remains in the guidelines. I think it remains in the guidelines for people with cryptogenic syncope. That's very hard to figure out, but it's very difficult because the reproducibility of tilt table testing, even in patients with known diagnosis, can be very difficult. So I would say that we clinically here don't do it very often, except in very severe cases.
Use of oral beta agonist terbutaline in the management of sinus bradycardia. Thumbs up, thumbs down? No
Thumbs
opinion?
down, pretty much. It's difficult, especially for an older population. And I don't know why you would be using it necessarily for a younger population unless it was for a vasovagal syndrome.
Is ischemic cardiomyopathy synonymous with coronary artery disease?
Yes. Ischemic cardiomyopathy kind of means that you've had some kind of coronary blockage that's resulted in scar in your heart that's presumably either a clinical myocardial infarction or something that's happened silently in the setting.
And then last question, is there a difference between complete heart block and high degree AV block?
Yes, but it's probably not important. So complete heart block just means you see that what I showed on the strip here, where you see atria, you see ventricles. High degree AV block can be paroxysmal, like you can see normal rhythm and then paroxysms of high degree AV block where you have no ventricular escape for a period of time, and then the rhythm resumes. So that's kind of usually what we're talking about when we say high degree AV block, but both are serious and probably warrant some treatment. So
great. Thank you very much. Really appreciate it. Thank you to the audience for sticking on.